Good afternoon, and thank you for joining Housing First, what it is and how it's implemented in California. My name is Sharon Report. I'm the Director of California State Policy for Corporation for Supportive Housing. On the webinar today, we hope to educate you on the model of Housing First, what it is and what it is not, the evidence on whether it's effective, and challenges facing housing intended to offer a Housing First model. I'll be one of the moderators on today's webinar. I'm from Corporation for Supportive Housing, or CSH, as I mentioned, and we're a national nonprofit that collaborates to advance solutions to use housing as a platform for services to improve the lives of the most marginalized people, maximize public resources, and build healthy communities. And I'm here with my colleague today, Christopher Martin, who's the Policy Director at Housing California. Housing California brings together a diverse multi-sector network to prevent and end homelessness, increase the supply of safe, stable, affordable housing, and reverse the legacy of racial and economic injustice by building power among the people most impacted by housing injustice, shaping the narrative, and advocating for statewide policy solutions. I'm going to turn it over to Chris now to walk us through the agenda.
Thanks, Sharon, and good afternoon, everyone. Chris Martin, the Policy Director at Housing California. We got a jam-packed agenda, have you for a little over an hour and a half, and time for questions at the end. But first, we're going to start with what Housing First isn't and what the evidence is behind it. We've got some great panelists there. Then we'll move on to what it's been like enacting Housing First in the state of California, and then move from there into efforts that have been made in recent years to either change or further advance Housing First in California. Of course, we'll have time for questions and answers at the end. Please be sure to put your questions in the Q&A box at the bottom of your screen. There will be time for Q&A after each of the first two panels, and then we'll have about 30 minutes to 45 minutes at the end after panel 3 for question and answers then. So please be sure to place your questions in the Q&A box and any discussion in the chat box at the bottom there. With that, I think I'll turn it back over to you, Sharon.
Okay, thanks, Chris. So we're asking everybody who's participating in the webinar, if you feel comfortable, to type in the chat just an answer to one of these two questions. And this will just give our panelists kind of your perspective on Housing First. So the first question is, what do you think Housing First means? And the second question is, what do you think the impact of Housing First has been in California? Again, you don't feel like you have to have expertise to answer this question. It's just asking your impressions or first thought on one of these two questions. So go ahead and type that in the chat box. And while you do that, I'm going to hand it back over to Chris to start us off with our first panel.
Thanks, Sharon. So our first panel is about what Housing First is and the evidence behind the model. We have 3 panelists for this panel. Margot Kuchel, I'll ask them each to introduce themselves a little bit further than I will. But Margot Kuchel will kick us off from the Benioff Homelessness and Housing Institute. Then Tim Hebben will speak about from the California State Policy Advisory Committee and Access Support Network. And then Dakshika Wikrama from the California Business Consumer Services and Housing Agency, our Deputy Secretary on Homelessness, will join us as well. So with that, I think I'll turn it over to Dr. Kuchel to start us out.
Hi, thank you so much, Chris, and thank you everyone for being here. I'm going to just give a broad grounding on what Housing First is and a sense of what the evidence is to support it and what it means. Next slide. So what is Housing First? So when I think of Housing First, what it is an evidence-based approach to housing people experiencing homelessness. It's an individualized approach, meaning there are a range of models that fit under the moniker of housing first. And one thing it most certainly isn't is housing only. And housing first is really thought of in contrast to an old model called treatment first. Housing first was developed specifically to meet the needs of people who experience both chronic homelessness and significant mental health or substance use disorder. So that was a population for whom it was designed. And it was adopted as federal policy for the first time under President George W. Bush. It had broad bipartisan support and was initially sort of brought up to scale in a Republican administration. Why is it important? Housing First speaks about immediate access to permanent housing without mandating engagement and services. So again, this is in contrast to a prior model, which asked for people, which the US did for decades, which sort of required that you work your way up to housing by achieving certain milestones and engaging in treatment before you would be offered housing. Housing First models most certainly include services, but housing is really the stability that clients need in order to engage with those services. So that is sort of the thinking and the philosophy behind Housing First, which has been borne out by the evidence that without the housing, it's almost impossible to engage in those services. It is supported by an extremely robust evidence base for several things, most notably its ability to provide stable housing over the long term for people who experience significant behavioral health conditions. And it should be noted that the VA has relied on Housing First as its model, and they have successfully reduced homelessness by over half in about the last decade by relying 100% on Housing First. Next slide. So what does the evidence for Housing First say? So across a multitude of studies, both in the United States and Canada, Western Europe, and other places, it usually shows a long-term housing retention rate of about 73 to 88%. The studies generally show dramatic increases in engagement in services, both as compared to the old treatment first model and as opposed to sort of usual care or just letting things fall as they may. What else does the evidence show? That it's essential that when we design these services, we match the services to the needs of the individuals using it. The evidence shows that it ends homelessness much more rapidly and much more durably than the other methods of doing it. And there's a increasingly solid evidence base of positive outcomes, including reductions in carceral involvement and recidivism. All of the studies show dramatically reduced reliance on shelter and dramatically improved housing outcomes. Next slide. What are the main service models? So one of the most important for those with the most severe behavioral health disabilities is called assertive community treatment, or it's often called ACT, ACT. This is low barrier, comprehensive community-based treatment that is offered in a model of rehabilitation and support services that centers the need for community integration and assertive outreach. Meaning while services aren't mandated, there's an assertive outreach to reach out to people to offer services. It also has low client to staff ratios, about 10 to 1. So it's the most service robust model. And the team includes a psychiatrist who's working alongside social workers, nurses, peer support, and others. The teams always have 24/7 access to somebody on the team. And the team provides multidisciplinary services, including mental health services, and links to community resources. So they provide case management, substance use, housing assistance, crisis management, and the like. Next slide. The second model is intensive case management. This is used for individuals who have severe behavioral health limitations or impediments, but less severe than those who qualify for sort of community treatment. It is less intensive than ACT. It is usually a team led by a master's trained behavioral health provider like an LCSW or an MFT, usually includes case managers and peers, and they do linkage to psychiatric care when needed and linkage to other services. The ratios are a little higher, usually more like 15 or 20 to 1. Next slide. Housing First, I just need to reiterate because there's a lot of mythology around here, like, well, this won't work for people who have behavioral health problems. That was literally who it was developed for. It doesn't make sense to talk about a housing first as opposed to treatment first and people who wouldn't benefit from treatment. There's incredibly strong evidence base for successful housing outcomes across multiple studies in research settings. And also in the real world setting, the most dramatic has been the VA, which has been appropriately scaled to see dramatic reductions. There have been good evidence for reductions in negative outcomes, most likely jail, psychiatric emergency department visits, and dramatic increases in engagement with services that we think are beneficial, mental health services, substance use services, and the like. All the studies have shown a dramatic decrease in the reliance on shelter. And they have also shown that it is true that a small group, usually once you find the people who need the high intensity services, there may be 10 to 15% of people amongst that small group who require a higher level of service. That is not 10 to 15% of everyone experiencing homelessness. That is 10 to 15% of the folks with the most severe complexity who qualify for these services who then benefit. Next slide. And I think that might be it. And I'm going to pass it over to our colleague. Thank you.
Thanks, Margot. And I will pass it to Tim Heaven, who can speak about Housing First from the perspective of somebody with lived experience. Over to you, Tim.
Thank you, Chris. Hello, everyone, and thank you for the opportunity to speak with you today. My name is Timothy Heaven. For many years, I experienced homelessness. I battled addiction. I faced incarceration. Thanks to Housing First initiatives, I was able to secure stable housing 3 years ago, transforming my life into one filled with blessings and purpose. I'm grateful for your time today, and I look forward to sharing my journey with you. Before I delve into my story, I'd like to just establish some common ground and just kind of reflect on a fundamental question. I kind of have a question for everyone, like, who here believes that life is a precious gift? Probably can't respond, but maybe put in the chat or something. Indeed, we all share this incredible gift of life on a beautiful planet, right? Fortunate enough to be here in the United States. In fact, yet not everyone has the same upbringing, education, or support systems. Not everyone has faced the same challenges, be it trauma, mental health issues, support systems, stigma, racism, or family dynamics. We each have our own unique stories. With this diversity in mind, I pose a question to you. Shouldn't we feel obligated as a community, as people, to uplift those who are less fortunate? Okay, imagine if life came with a contract offering all its beauty and opportunities with just one condition, that we help those in need. Would you sign that contract? So please take a moment to consider, if such a contract were real, would you find it fair? Is it too much to ask that we commit to supporting and uplifting the less fortunate? I urge you all to approach today's discussion with empathy and understanding as we explore how initiatives like Housing First not only change individual lives, but also enhance our community's well-being. Okay. I would like to share my personal journey with Housing First. Before getting to Housing First, I have experienced many years of homelessness due to a number of circumstances, including job loss, breakups, etc. The most recent episode I faced was actually a result of nothing more than a serious and substantial amount of injustices being carried out by failed government-funded programs. My phone call to law enforcement for help in the best interest of my child to prevent a domestic situation ended up backfiring on me and my 3-month-old son being taken away from CPS without a warrant after a 2-second investigation. And thanks to social workers blatantly lying in court petitions and all my due process rights and right to fair trial taken away in an ex parte hearing, I was forced to have to complete their case plan to even have a slight chance of reunifying with my son. This case plan required me and the mother of my child to separate. So I ended up having to move out of our apartment, and now I had no job due to COVID and nowhere to call home. I was officially unhoused. Just to be clear, I assure you that I pride myself in and being a great father to my son, and that he was well loved and well taken care of, and there was never any abuse in any way whatsoever. I just remember feeling completely traumatized from all these events that I couldn't believe were unfolding in front of my eyes. So much injustice being allowed to take place. I believe I couldn't stay at my mother's house because she had my son, and there was a protective order placed against me, and I wasn't allowed to see him without CPS or court permission. So, I was an addict in recovery, nearly 2 years clean at that time. I was able to scrape up the last bit of money I had to purchase an RV to sleep in. It didn't run, and I had to find a place to park it, but at least it was something. I ended up at an encampment towards the outskirts of Seaside where we were allowed to stay during COVID, but that didn't last too long. As soon as COVID ended, the encampment was forced to move the very same day, as they had a project plan for the site. We pleaded with the city officials to be allowed more time to obtain housing to get into a program, but we're told that they needed to break ground on the project. This lot remains empty and unchanged to this day. I started noticing a lot of injustice being done and nobody really having a voice for myself or the unhoused folks around me. And decisions were being made that directly affected us, yet we had no say in the matter. That just never sat right with me. I have always worked my entire life and thought the one good thing about COVID ending is maybe jobs will open back up, and they did. However, most of my time and energy each day went towards figuring out where I was going to rest my head at night or where I could park during the day without fear of getting towed. I would get kicked out of one parking lot, and every time I had to move, I had to be careful not to risk getting pulled over and having my RV taken as my tags were expired. I was constantly being harassed by law enforcement and even folks in the community that didn't like the fact that I was parked in the Home Depot parking lot. As much as I would have loved to get a job, I first had to worry about where I could eat, where I could be at, what I was going to do to take a shower, how I could get my clothes cleaned and ironed so that I could look presentable. And on top of that, I had to do all these things with my CPS case open and all the requirements that they had. The trauma from having my son taken from me and all of the injustices happening really made me feel like just giving up. I turned back to using drugs just to cope and deal with life and numb the pain I was feeling. I contemplated suicide on a number of occasions. It was incredibly challenging living on the streets, just trying to survive day to day. You really don't realize how easy you got it when you have a roof over your head, running water, electricity, or a stove and microwave. Thankfully, I had been very proactive in trying to obtain housing. I knew that if I just had this stability, I'd be all right. I did a housing assessment to get into Puerto Del Mar, which is a sober living environment where they provide you with housing if you have a child or child you'll be getting back. My mentor dad worked there, and it really would have been the best case scenario for me. To my shock, I actually got accepted, and all they needed from me was a letter from CPS saying that I would reunify with my son within 90 days. And I begged and pleaded for them to provide this letter, and they refused to provide me with this letter, even though weeks prior we had an agreement that if my housing passed inspection, I would get my son returned. This just caused me to start using more with the drugs, and I just felt like a complete failure and that I had nothing left to live for. I really just had to put my faith in my higher power at this point, that this has to be all part of his plan. And I started thinking that maybe all these things were happening to me because he knew I'd be strong enough to make it through. And I'm intelligent enough and have enough common sense and righteousness to be able to share my experience and to shed light on what's being allowed to take place in our country and society. Something to keep in mind is that data and statistics clearly show that a significant amount of unhoused people have had involvement with the foster system in many areas, nearly half the unhoused population. I had a tremendous amount of distrust and fear at this point, anything to do with the government or government-funded programs. I have signed up for so many housing programs in the past prior to renting a couch or room somewhere, and I was always put on a waiting list. Or there were numerous barriers in place preventing me from obtaining housing. It was always that I had to be clean and sober, my credit didn't qualify, I didn't have a stable income, my criminal record, you name it. It always felt like it would be impossible to get into housing. Apparently, my name was placed back on the list after not being able to get into Puerto Del Mar. And when I got the call that my name was next on the list and I would be getting into housing, I was so thrilled, but still very, very skeptical. I thought for sure more discrimination was headed my way and wasn't planning on holding my breath very long. I never heard of Housing First before at this time. They told me I would be able to get into housing in a neighboring county, which I didn't mind. I thought that'd be help me to get clean and if it wasn't as easy for me to access the drugs, it'd be easier for me. For a long time, I thought that I might actually get into housing. It was just a nice thought, you know. I knew that my criminal record was going to pop up, or maybe I would fail a drug test, or they would find some reason why I couldn't get into housing. I honestly don't know where I would be at today if someone didn't give me, if I couldn't get into housing. And someone didn't give me a chance. In all reality, I might not be alive today, honestly. I'm proud to say that I have been clean and sober for a year and 10 months today. Thanks to Housing First, any barriers that I had faced in the past no longer applied. All efforts were made to simply get me housed by any means necessary. I couldn't believe the progression that has been made that would provide someone like myself with this opportunity. I was honestly in disbelief until they gave me the keys and was actually able to secure housing. Even a while after, I just felt this was too good to be true, that they're going to find out I'm still using, that I'm on probation or something to kick me out. Housing First principles involve taking every measure to support us once we are housed. And the last thing that they want is to find any reason to get back, to become unhoused. Housing First provided me with the stability I needed to get back on my feet. I was just so relieved. I felt like someone was finally looking out for me, and they were. I had a case manager now, and that is very supportive and encouraging, and really continued to meet me where I was at and just motivate me and encourage me to progress and help me take certain steps to improve my life and live up to my full potential. I will forever be humble and grateful, and Housing First showed me that what compassion looks like. Being unhoused allowed me to see a lot of injustices I felt were taking place towards people, and so I decided to get involved and represent the unhoused community and be a voice for the voiceless and do my part to give back. Since being housed 3 years ago, I was able to join the Continuum of Care Leadership Council as a lived experience member in Monterey and San Benito County. From there, I created and I'm the chair of the Lived Experience Advisory Directive, or the LEAD, which we have 15 members of people with experience of homelessness that acts as an advisory to the Leadership Council. I'm also on the Community Action Board for San Benito County, as well as this California State Policy Advisory Committee with the Corporation for Supportive Housing. I also work full-time doing homeless outreach with Access Support Network, and have been building relationships with many members of the unhoused community over the last 2 years. I graduated from drug court. I made it off probation. One of the pivotal moments in my life was when they had the Lead Me Home Summit on homelessness last year, and I was actually honored in front of hundreds of local leaders and officials and was awarded with the Community Hero Award. I'm at the forefront of outreach work and advocacy within my community. I co-host a local radio station on Sundays and try to spread the message to people to keep loving and keep shining. About a month ago, I was out doing outreach, handing out harm reduction supplies and testing unhoused people for HIV and Hep C as part of our harm reduction efforts. And I just finished testing a client when she started to cry. She's been unhoused on the streets for many years, and she just thanked me. She was really worried that she might have contracted HIV due to someone carrying it out there. I felt kind of bad because I knew who she was and couldn't remember her name, but she remembered my name, and she tells me, you know, that a lot of people out here are talk about you. You're an inspiration for a lot of people, and how you're always trying to help everyone, you know, and so those moments really assure me in the purpose that has been filled in my mind and me and my spirit. The more I write about this and think about it, Housing First made it possible for me to have the purpose and accomplishments that I have in my life today. I mentioned that I obtained my community health worker certification, but I also received a scholarship and am taking college classes to obtain my addiction counselor certification. I'm the first community health worker contracted with Medi-Cal in San Benito County and opening up my own organization, Heaven Helps. I am able to spread the love that was shown to me, thanks to a program that is based out of love and empathy for those that are less fortunate. There is plenty of data to show the effectiveness of Housing First is an evidence-based approach. I am living proof of evidence that Housing First works. I love my life today. I may not have been able to get my son back because there was no winning with the corruption at the level I was to fight it at, but I'm still able to see him and spend time with him every day, as my mom allows. I love the work I do with the unhoused community. Coming from Narcotics Anonymous and going to work in harm reduction was a learning experience for me as well. Once I started doing this work, it made complete sense to me. The unfortunate truth is that many of the unhoused people living in our streets have all been given up hope on housing, their health, and really just their life in general. I'm able to be out there today to spark a little bit of hope back in their life. I know firsthand, the more you try and force someone to do something they don't want to do, what is usually the outcome? I don't think anyone likes to be forced to do anything they don't want to do. Many unhoused people use the syringes to inject drugs and typically would share needles, and a lot of diseases like hepatitis C and HIV was spreading rampantly. Working harm reduction effectively involves a strategic approach and implementation and has many benefits. Harm reduction is a logical approach to be able to help the most traumatized, vulnerable, and persons with severe mental health conditions to be able to stay alive long enough to hopefully start to feel like they are cared about, to start caring about and loving themselves enough to want to start taking steps and making some changes in their life. We provide clean syringes to help stop the spread of disease and infection. At the same time, we provide different using utensils, pipes, condoms, mouth guards, alcohol wipes. The goal in mind of working on switching people from injecting drugs to smoking. Once we can make progress here, we can work on cutting back their usage altogether. Harm reduction services allows us to engage individuals that we normally wouldn't be able to engage with. We have doctors and nurses that we work with, and we offer low barrier Suboxone medicated treatment, which is really a miracle drug and the most effective means of getting people off fentanyl and opioids. We have been able to help so many people get their lives back by offering this during our harm reduction services. People trust us. We also hand out a substantial amount of Narcan. Every day we are saving lives, and we hear from our clients how many lives we are saving just providing them with the Narcan. It's a scary time to be using drugs right now. The strategic approach we take involves offering clients on-site testing for hepatitis C and HIV. We were able to get people tested and provide them with results instantly. Many unhoused residents are living with hepatitis C unknowingly. And when they find out they are reactive, we are able to get them started on treatment. I can't tell you how many times we have tested someone and getting them started on treatment and taking the time to show them that we are there for them and we care has opened up so many windows of opportunity, and many people's lives have been transformed just because of this. See, once they receive this help getting treated, there's a harm reduction step towards them starting to think about their health and wanting to start improving in other areas of health they weren't considering prior. We collaborate with other service providers to do housing assessments and offer them other resources. Harm reduction is really a psychological approach that really happens naturally with the right encouragement, strategy, and implementation. People should have the autonomy to be able to make their own decisions. In fact, any type of recovery, I don't think people have any chance if it isn't their own free will and their own decision. I just want to touch on harm reduction a little bit, and the effectiveness of harm reduction really is in the approach, implementation, and strategy. Harm reduction saves lives. Thank you all for allowing me to share with you today. I apologize if I rambled on too much. I look forward to any questions or comments. And again, I urge everyone here to consider the decisions they make that will affect people's livelihood. And just consider if you're coming from a position of love and empathy towards our fellow brothers and sisters in humanity, or what position you're coming from. Thank you, guys.
Thank you so much, Tim, for sharing your story, which is a true testament to the effectiveness of Housing First and harm reduction and truly your perseverance over the years. So thank you for sharing that with all of us. Next, we'll go over to Dakshika, who is the Deputy Secretary on Homelessness for the state. Before I throw it to you, Dakshika, I will just remind folks to please put your questions in the Q&A for all three of these panelists. We will have a few minutes momentarily after Dakshika's presentation to discuss that. With
Thank
that,
you,
I will
Chris.
turn it over to you, Dakshika.
Thank you, Chris. And Tim, thank you so much for sharing your story with us. And I think you can see with Margot's evidence that she shared, Tim really made it come alive. So thank you, Tim, for doing that. And my task today is to really talk about what the state law says around Housing First. But Margot and Tim have really made my job easy because Margot has provided the research-based evidence and Tim just explained why Housing First is so needed to make people, really it's a life-saving approach, but I will get more into that. First, I want to highlight 3 bills, all building on each other. So in 2016, based on the evidence that was surfacing, the testimony from people with lived experience like Tim, Housing California and other advocates really helped the state legislature put forward and approve this bill, Senate Bill 1380. And that established what we now call the California Interagency Council on Homelessness. But at that time, it was called the Homeless Coordinating and Financing Council. That entity at the state was established to oversee the adoption of the Housing First statute into guidelines and regulations. What that bill did was it also defined Housing First, and I'll have some more of that language in the future slides, but it also kind of described 11 core components for programs addressing homelessness. And many of those core components, when I get to them, you will see Tim and Margot have already talked about. The second bill is Assembly Bill 1220. So that was later on, but what it did was, one, it restructured the Homeless Coordinating and Financing Council and created the California Interagency Council on Homelessness that we have right now. But it also clarified that Housing First applied to state programs funding emergency shelters. Then the third bill, Senate Bill 197, clarified requirements for specific state programs funding recovery housing. So these are the three bills that kind of lend itself in California law around housing first is defined and how it should be applied. Next slide, please. So I'm just going to read this because, again, this has been said before, but I thought it was important. This is how housing first is defined in California statute. Housing first means the evidence-based model that uses housing as a tool rather than a reward for recovery, and that centers on providing or connecting people experiencing homelessness to permanent housing as quickly as possible. As you heard, Housing First providers offer services as needed and requested voluntarily and do not make housing contingent on participation in services. Next slide, please. So I know there's a lot of words on this slide, I apologize, but these are the 11 core components as described in California statute. And many of these things, again, Margot and Tim went over, but I'll point you to especially, for example, core component 1, tenant screening and selection practices that promote accepting applicants regardless of their sobriety or use of substances, completion of treatment, or participation in services. Or core component 4, for example, that Tim talked about, supportive services that emphasize engagement and problem solving over therapeutic goals, and service plans that are highly tenant-driven without predetermined goals. As Tim mentioned, this really enables and empowers the client to take charge of their lives and really achieve housing that's stable in the long term. And then core component 9, which Margot mentioned and Tim mentioned, case managers and service coordinators who are trained in and actively employ evidence-based practices for client engagement, including but not limited to motivational interviewing and client-centered counseling. And then core component 10, which has been talked about and really again brought to life by Tim's story, services are informed by a harm reduction philosophy that recognizes drug and alcohol use and addiction as a part of tenants' lives, where tenants are engaged in non-judgmental communication regarding drug and alcohol use, and where tenants are offered education regarding how to avoid risky behaviors and engage in safer practices, as well as connected to evidence-based treatment if the tenant so chooses. So I'm just excerpting a few, but all 11, of course, are very important. And then next slide. This just summarizes the previous slide because it shows really the different ways Housing First can be applied in programs. But the context column, I think, is important because I think it provides that why. Why is that core component so meaningful in the life and trajectory of an individual or a family that is experiencing homelessness, that is struggling to find housing, that is attempting to access interim housing, permanent housing, and or services. So these core components and the context really show you why Housing First really helps meet people where they are and really think about how you can take that journey together so that people achieve stable housing for the long term. Next slide, please. I mentioned the California Interagency Council on Homelessness on the first slide, and just wanted to point out that for the state of California, CalICH, as it's sometimes referred to, has been established in statute in its current structure to really oversee the implementation of Housing First at the state, especially when it comes to state programs. So the 11 components we just went over, CalICH staff really review those core components and are doing the work of assessing state programs, providing recommendations, resources, and guidance, and making sure that they can be a thought partner and resource guide with other state agencies and state departments in California that are carrying out programs to address homelessness. In addition to collaborating with state partners, CalICH also expands the focus on the community level where they provide trainings, resources, guidance, best practices, and also uplift trauma-informed, and culturally appropriate practices. Just as Tim is on a lived experience advisory board, CalICH has a lived experience advisory board as well to really ground the work with people with lived experience and expertise. And there's a state council, which includes state agencies and departments, and 2 members appointed by the legislature. Actually, Dr. Kushel is one of the council members on the CalICH State Council. So these are the different ways that CalICH really oversees the implementation of Housing First through the convening of state bodies and state departments and agencies, but also providing best practices for people on the ground. Next slide. So given that role, please do note that CalICH staff are available to continue to provide guidance. Since this is a legislative briefing, I've listed our legislative specialist at BCSH and CalICH who can be available if there are any questions from legislative staff. But just to reiterate that CalICH is available to increase understanding of implementing Housing First, assessing the need for guidance on specific topics, and seeking best practices and successful examples to uplift and share. That's it for my presentation right now, Chris. Back to you. Thank you.
Thanks so much, Dr. Shiga. If folks can please add any questions to the Q&A, I can get to them and let's read them for folks. I do notice one about recovery housing. I will say the next panel is really going to dive deep into recovery housing and what that looks like, and the model for that. So I noticed that is one of the questions in there. Maybe while we wait for folks to add any questions they have, I'm wondering if Tim, Dr. Shika, and Dr. Kushel, if you could speak to, when we think about what about housing and in a Housing First harm reduction model, what does that housing look like? What kind of services are typically offered? What is the housing intervention that we're really discussing here in kind of concrete terms? Could you all speak to that?
Yeah, I put something in the chat too. Just I felt like maybe this was like geared towards like as an addict in recovery myself. I think there's a fear of housing with someone that may be using still, right? And I look at that as an opportunity. The core of Narcotics Anonymous is to be able to give back what was so freely given to us. And I always look at those that are still suffering as an opportunity to grow in my recovery by doing my part to help those that are still suffering. And so I'm just assuming that that's what they're talking about. But I think the success of the program it relies on the person and then also the support. There's linking them with the right support, and then it just to cater the support to their needs though is really important.
Yeah. Thank you, Tim. Maybe I can talk. I mean, there are a variety of models, and a few things to know is that, supportive housing or Housing First can be done in what's called a project-based model, where there's like a building with lots perhaps of studio apartments and a shared space, or it can be done what's called a scattered site model, where the organization would lease apartments and individuals would be in those apartments throughout a community. It doesn't have to be a building. It can be a building, but it doesn't have to be a building. It can be, apartments leased throughout a community. And the support services, I think the key is that there are a variety of models. What the evidence sort of suggests, though, is if folks have significant levels of either mental health conditions that are disabling or substance use disorders, they are going to benefit from the more robust models. So the more robust models are either these ACT or the ICM models, but those don't have to say fix over time. People recover, they get better, they need less, and they might then need, just having a peer support in the building to connect them with services if they need something. So there can be a variety of models, but what the evidence shows is either scattered site or buildings work, depending on the person, depending on the community, and that the level of services should really match what the person needs. It can include as much as having sort of a psychiatrist with a relatively small caseload and a nurse and a vocational counselor and a social worker and a case manager. It can include having a social worker and a peer and a case manager working with a panel of people who they are connecting to services if they don't provide those services. So it can either be like a brokerage model or a direct service model.
Anything you want to add to that, Dakshika?
Yeah, one thing I was going to add is we've talked a lot about permanent housing settings, but just emphasizing that, as Tim mentioned, even in interim housing settings, or even when you're doing services, there's a way to really think about harm reduction and housing first approaches. So just wanted to mention that, of course, everybody's trying to create a pathway to permanent housing, but there's a way to have these approaches because fundamentally we're trying to make sure people are not dying on the street. And so housing first and harm reduction is a way to make sure that we are using techniques and approaches and collaborative relationships to keep moving people into safer spaces.
Really helpful. I think it's two good questions in the chat. One is I don't know if folks want to take one of these about how you implement housing first when we have such a housing crisis in California and a shortage of housing. And the other one's about if there's disruptive tenants and how that is handled in a housing first setting. I don't know if folks want to take one or the other.
I can
I'll
try
start
to
to
take the,
answer it
sorry,
in the
go
chat.
ahead, Tim.
Yeah, like I agree, right? So in order for housing first to work, we need housing first, right? And that is the dilemma we're facing in California, right? I mean, in my perspective, I mean, we just have not kept up with the supply and demand, right? There's obviously a lot greater demand for housing than there is supply. So that's kind of the crisis we're in. But I think that also kind of falls back onto our government to be able to come up with these solutions for housing. You know, we obviously we need the funding for housing. You know, we can't just, you know, and there's a lot of barriers in place to be able to build new housing. I mean, there's a lot like we met with the Senate in April, and she said, I think Marie Gill told me that it's going to cost $1 million a person to build housing in California, which is kind of ridiculous. You know, I couldn't believe it, but she was being honest. I mean, as when you get past all the fees and stuff, everyone's, you know, all this money's out there, and every time this money's out there, everyone wants to grab their hands and, oh, I want my cut, I want my piece, you know, and that's caused a lot of issues in California as far as developing goes.
I mean, I think you're right, Tim, that the housing scarcity does help, prevent the scaling up, right, of housing first, because it's, imagine like in COVID, if you think about housing as a vaccine or an antidote, the problem is if you don't have enough of those vaccines, it's very difficult to provide vaccinations to everybody. So similarly, I think the challenge has been the lack of housing. I will say, even though I'm not sure the person who mentioned about the $1 million person, really, if you think about how long the housing that's affordable is built to stay affordable for 55 years. So it's unlike housing that I rent or I buy, which I just live in, and it's not necessarily kept affordable for people who are low income, right? Housing that's affordable, that's built by the government, generally is going to last and stay affordable to low-income people for 55 years. So you can't necessarily compare the costs of building market rate housing to the costs of building affordable housing because the government and the nonprofit partners and everybody involved are making sure that that rent level stays affordable for people who are low income and extremely low income for 55 years, which is not the case for normal housing. So just wanted to mention that you can't really compare apples to apples like cost of building, but take your point about the lack of housing.
And I think the one other thing, I couldn't agree more with that, because we're often throwing around this number and not sort of amortizing it over time and things. But the other thing is that housing first is in opposition to treatment first. And housing first is a much more efficient way to use the housing that you have. We're not going to solve the homelessness crisis without creating, preserving, protecting, and producing a lot more deeply affordable housing. Housing first is saying, how do we use the housing that we have? And when compared head to head, you have a lot less churn, you have a lot less eviction, you have a lot less empty housing. And so I think people sometimes are having different conversations. We have the heart of our homelessness problem is we don't have enough deeply affordable housing, and everything we have to do in the state has to focus on that 100%. And then there's a question of, we have a certain amount of housing. How do we distribute it? And I can tell you that the most effective and efficient way to do that is through Housing First. And don't get sort of confused by all of the folks who are talking that. If you want to keep that housing filled, if you want to keep people thriving, then you use a Housing First method to use that housing. It's really about how you use the housing that you have. And absolutely, we need to do everything we can to produce, protect, and preserve deeply affordable housing.
I did want to just touch on I was in agreement that there's a lot of barriers in place. I really do not believe that it costs $1 million a person. There's a lot more effective programs out there. Like, I think the most effective one is the hotel conversions. Unfortunately, we always face these issues in our state, with one of them being with the developer, Shangri-La. They kind of did a Ponzi scheme on a lot of these developments that were taking place and kind of halted momentum on these projects. But there's a lot of these projects that we could still do that will provide housing for a lot of individuals. So just want to put that out there.
Yeah.
No, appreciate that, Tim, and only because this is a webinar and in case people find this useful, that hotel conversion program, Tim, that you just referenced, which also called Home Key sometimes, that has collectively created 15,000 affordable apartments across California, more than 15,000 and more to come. So just wanted to mention that because of course, even though that sounds like a lot of affordable apartments that are affordable to low-income families and individuals, we need to build more, but we've done a lot. Just wanted to make sure you have that statistic.
Yeah, thanks, Dr. Shika, and thank you all. I appreciate this panel. I appreciate you all for sharing. And with that, I will turn it over to Sharon to lead our next panel. And just another reminder, put your questions in the Q&A.
Thanks so much, Chris, and everybody who presented. Really great panel. As Chris mentioned, we will have time for more questions and answers. So I think there may have been one or two of you who didn't get your questions answered yet, but you will. So next we'll be focusing on enacting Housing First in California. And we have 4 panelists in this section. The first is Jonathan Russell, who's the Director of Housing and Homeless Services in Alameda County. Then another Jonathan Castillo, who's the Chief Regional Officer for PATH. Jolene Gillian, also from Corporation for Supportive Housing in our Los Angeles office. She's Associate Director. And Amiyoko Shabazz, who's a housing justice advocate. So let's start off with Jonathan Russell. I'll turn it over to you, Jonathan.
Thank you, Sharon. Appreciate that. So as Sharon said, my name's Jonathan Russell. I'm the Director for Alameda County Health, Housing, and Homelessness Services. We're the lead agency overseeing and providing the coordination among many providers and others doing work in Alameda County. Though I, for a long time, was a service provider doing direct service work. And so much of what I'll share today is based both in that experience and now as a system administrator. So wanted to share a little bit about the intersections between harm reduction and Housing First. We can go to the next slide. So first, a little bit about harm reduction, what it is and what isn't it. So harm reduction is, in summary, centered on building empathetic relationships, which are grounded in dignity and the value of choice and self-determination, informed by both the individual and structural drivers of behavior, and focused on pragmatic ways to support safety, healing, and recovery. That is both a mouthful, but I think I tried to highlight some of the key words I think really gets at the core components of harm reduction. First and foremost being building empathetic relationships. If we think about the core of many of our best practices, but also those rooted in trauma-informed care and others, truly the heart of harm reduction is that no positive benefit in the way we work with folks can really happen unless there's a bedrock of relationship. And that relationship, of course, is the space in which support can happen. In addition to that, that is the way in which we sort of support dignity, right? A dignified relationship is one where we have trust and we treat it as a relationship. And there's a real difference there between transactional and coercive relationships. The key as well is also choice. So harm reduction is about supporting individuals to support their choice and self-election in their lives. In the same way, when we think about harm reduction, which again, I should say, and we'll come back to this, harm reduction is about supporting people to reduce harm, and is applicable to all kinds of high-risk behaviors. It is not just about substance use. It's really about reducing the harm of a variety of behavioral contexts and situations. Given that, one of the core principles of harm reduction is that it really is a philosophy that is informed with awareness that there are both individual, personal drivers for certain behaviors, but also structural and environmental drivers. So being cognizant of that, which we'll talk about more on the next slide, is a core principle of harm reduction, that we're not just focused on the individual as the individual, but the factors and the structural, both systemic in society and both environmental locally for the person, that are factors in the decisions they're making in their lives. And then lastly, harm reduction is deeply pragmatic, which is to say it is focused on what are the ways in the present and working with people in the moment and in their lives as it currently stands with a realistic understanding of someone's needs. How can we support people to be safe and to heal and recover? So what harm reduction is not? It is not just relevant in the context of substance or alcohol use, but all kinds of high-risk behaviors. So higher risk sexual behaviors, survival sex work contexts, all kinds of different environments where in which decisions might be being made that are high risk. Harm reduction and the principles of harm reduction can be applied in that setting. Harm reduction is also not opposed to abstinence or treatment when those decisions are grounded in exactly that, when they are decisions. So as long as choice, supporting the individual is central, harm reduction is not in any way opposed to an individual is being supported in choosing abstinence or support for treatment. And then lastly, harm reduction, as I often say, harm reduction is not license. It's not do whatever you will without consequences. It is really focused on supporting people, treating people like humans with the awareness that there are consequences for actions, and we each are all responsible for those consequences, but really supporting people through that process. Lastly, and I like to think of these as a versus one versus the other, and sort of trying to draw a distinction between what harm reduction focuses on and what it doesn't. And these are, I call them the two kind of, for me, the core principles of this philosophy of care is really, it's about distinguishing trusting versus transactional relationships. Trusting relationships, as we talked about, are built upon a mutual sense of respect, whereas transactional is built on an exchange, often a coercive one, where if you do this, you can get this. And many of our service environment contexts historically have centered transactional coercive ways of working, and that does not often support choice and empowerment and long-term healing for folks. Additionally, and I think the core question I always use in doing a training about harm reduction is we have to ask ourselves the question, are we doing work that is cultivating safety, or is it enforcing control? Distinguishing the difference between supporting people to cultivate an environment where people are safe, or in my own way, enforcing a control on a situation is really an important distinction, where in which we see harm reduction focused on the former, which is to cultivate safety. Next slide. So how does this integrate with Housing First? I often do Housing First trainings and talk about Housing First, and this is the best way I've come up to kind of summarize what I think is the core of where these ideas intersect, and it's this. Homelessness is a housing problem, not because everything else is irrelevant, but because housing creates a dignified space where anything else can safely become relevant. What does that mean? That means all of the factors in our lives certainly may be factors that we want to deal with or address or work through, just like I've got all kinds of stuff that, right, I need to spend time on or what have you. So to say Housing First and to say housing is the solution to homelessness is to say that housing, like so many other needs being met, is fundamental to create a space where I can even take the time to think about and address and focus on some other decisions, right? It is a core function there. So housing is, I like to think of Housing First as an environment first philosophy, right? Let's make sure that we are creating a space, a dignified space, wherein which I can be an environment to think through and make other decisions. Within that, what comes to light very clearly is that the way harm reduction and Housing First intersect here is that housing without conditions, right? That's the core of Housing First. It's not coercive. You don't have to do this to get this. Housing is available regardless of one's participation in services, right? That approach promotes that safety, right? What I don't have to worry about losing this thing, right? And it promotes choice, that I'm going to choose to participate versus having a coercive relationship, right? With this context or with this care worker, right? So those lack of conditions promote safety and choice as opposed to control and compliance, right? Behavior that is focused on just complying with something because it's a rule versus identifying and making choices with our own lives. Always the long-term impact is that compliance will fade when the control leaves, right? So it's a non-empowering environment. In a similar way, Housing First serves as the context for those trusting, non-coercive relationships, right? When housing is provided, it provides that dignified space where in which we can truly build trusting relationships and folks can think about, can rest, can take a breath and make decisions for their lives, right? In a similar way, I often think, describe it this way. Housing First is just housing in general, right? I don't need to sort of sort everything out or check certain boxes other than I have, right, got the support or whatever to move into the unit and sign a lease. Housing First is just the same thing, right? That everyone doesn't have to have all their things sorted out in some or in personal lives in order to access housing. And I can tell you, if I did not have housing or a stable place to be, none of my stuff, big and small, would be even remotely addressable. Which leads to the last point, and I'll leave it there after for some more discussion if it comes up. But Housing First is fundamentally about removing barriers and environmental factors that often exacerbate high-risk behaviors. I think Timothy gave a wonderful example of the way the sort of trauma and stress and strain of living in unhoused settings, of being constantly moving, actually is more of a causal factor in folks using than what causes folks to fall into homelessness. Very many people see that the use is an adaptation to a traumatizing environment versus vice versa, right? So when we think about environment first, we say, I need to alleviate those environmental factors for which use or other high-risk behaviors are an adaptation, often a survival adaptation. We think about this when folks are doing survival sex work. We need to fix the environment and realize that and removing those barriers is the core way that we help people manage high-risk behaviors or deal with those. And so, yeah, I think that's the last slide I have, but that's how harm reduction and Housing First fit together, and they work very well together, and they're dignified and serve people well.
Thank you so much, Jonathan. Now we're going to move on to Jonathan Castillo.
Hi, so I am the Chief Regional Officer with PATH. We are a homeless services organization that serves the state of California. We serve all the way from Santa Clara County to Santa Barbara, Los Angeles, Orange County, and San Diego. We provide a lot of supportive services on site. Right now, we currently have a total of 2,000 permanent supportive housing units throughout the state, with about 1,000 units in the pre-development phase. And then in addition to that, we work with a lot of housing developers as well, where we provide the supportive services to their projects, which total to about 1,000 units as well. In addition to that, we also provide a lot of scattered site services. I know that was mentioned earlier. So we have a lot of experience in providing supportive services using the Housing First model in a number of scenarios. And so what I'm going to be talking to you about this evening is really what this looks like in practice from a service provider model. Go to the next slide. So we're going to be talking a little bit about client choice, service objectives, service engagement, the interdisciplinary service models, and supportive services. This is supposed to say on-site and community-based. That was a little bit of an error. I apologize for that. But part of the reason why we're talking about what it looks like in practice is that this is critically important when we're looking at and evaluating the success of Housing First. There are some perspectives that Housing First, in different communities that we serve, sometimes we hear that people don't feel that it's successful or that it's not working. And so one of the things that I would challenge this group this evening to do is when those thoughts and opinions come up, the first question that we always want to explore as a service provider is, what does the service design look like? Because many times what we see in serving so many different communities throughout the state is because there's sort of scarcity with funding, sometimes program designs are created in a way that don't really outline a lot of the information they've heard here this evening around low caseload ratios and being able to have an interdisciplinary model. So the model's significantly diluted, which impacts the success of the program. So it's really important to kind of understand what it should look like. The first thing we're going to talk about is client choice. I know that this is something that you've heard a lot this evening around it being person-centered services. So what does this mean? You know, that individuals, I saw there was a question in the chat around, what if the person wants to pursue sobriety or is currently in recovery? That's okay, because in Housing First, people choose their level of engagement in services and what it is that they want to focus on. They develop their own goals, recognizing that that we've encountered a lot of folks who are not in recovery on the streets, but have a desire to pursue recovery, to engage in treatment. So it's really kind of allowing for them to give them the space and a very non-judgmental approach that we're working in collaboration to support them in developing their goals. And then lastly, it's they are actively participating and are the decider in what their housing option looks like. We talked a little bit about scatter site housing, which is working with private market rate landlords in the community is one model of Housing First. And then the other one is project site or project based, right? Permanent supportive housing buildings where they're dedicated or have a percentage of the units dedicated to serving people who are formerly homeless. So making sure that they have a choice in that and in selecting a home that best aligns with sort of meeting their needs. The service objectives are completely focused on housing retention. And so with that said, it's inclusive of the whole person. So looking at the different social determinants of what is it that we need to support them on to retain that housing. So social relationships, a lot of individuals that when they come into our programs, they've lost relationships with their family, with their loved ones, with friends. And so it's helping to support with some of those connections, spiritual connections, if there's a spiritual religious belief that they hold, that we're also kind of supporting getting them connected to their spiritual community or religious community. Physical and mental health, a lot of our services are focused on providing coordination and linkages to physical health, getting established through a primary care provider or a mental health provider. Money management is a big area of focus because we work with folks who might be on a fixed income. And so making sure that we're really kind of spending time on that budget of making sure that they're prioritizing you know, a portion of their budget for paying rent, a budget of their portion for groceries and for utility bills. Or it might be that some folks, once they're stably housed and they're moving through their goals, they might have an interest in pursuing employment. So we're supporting with employment as well. And then also being a good neighbor and upholding their responsibilities as a tenant. And so some of that could just be kind of, you know, what does that look like day to day? Being mindful of maybe the volume of the music that you're playing or how you're interacting with neighbors, you know, how to kind of organize your apartment or supporting with grocery shopping. So a number of those things around kind of being a good neighbor and what that looks like. Service engagement is really important because in a lot of the time that we've spent working in different communities, when you say case management or supportive services, it's a very sort of broad term that we've worked with a lot of providers as well that provide desktop case management. That's not what supportive services are. Supportive services are community-based services that are taking place in the home, outside of the home. It could be somewhere in the community, maybe the doctor's office, maybe, you know, at the DMV. It also takes place in the office. And so the services go to where the need is. but we always kind of, stress the importance of doing home visits as frequently as possible because it's really important to see the person in their environment. The interdisciplinary service model is really important. It was mentioned earlier that there's the ACT and ICM model. Regardless of what the model is and what the funding stream is, we always strive to have an interdisciplinary service model because we've seen the advantages of having a case manager who's purely focused on the case and the linkages needed to connect them to help sort of with the housing retention. Having a clinician that can really kind of pick up on what the behavioral health needs might be, having sort of a trained eye of like, you know what, this behavior might be a symptom of this behavioral health diagnosis. And then having a medical staff is incredibly important as well as being able to provide some of that service on site because, some folks might not feel that they need to go to the doctor's office until you have somebody or a nurse saying, you know what, we're seeing that there might be, a benefit for you to go to the doctor's office and kind of building the trust on site and having them maybe go to getting connected to primary care provider. And then lastly, peer support specialists. This is a person with lived experience where they're really leveraging their lived experience to engage folks in services, whether that lived experience is someone who has experienced homelessness themselves, or if you're serving a veteran population, somebody who is a veteran, if you're working with folks who you're primarily focused on reentry, it's, somebody who might have reentry experience, but the lived experience has a nexus to the population they're serving, and they're really leveraging that to increase engagement in services. And lastly, this is my last slide here. Supportive services I mentioned earlier happen on site and they're community based. For a lot of our scattered site programs, our case managers are in the field. They are traveling from apartment to apartment, doing home visits. And then some of our permanent supportive housing sites, the case managers are co-located. So they're based, in the building, where they are just, on the first floor where they're kind of highly accessible to our tenants who are there. And there's a lot of advantages to both models, and I think it's important that we're offering both options. But the most important thing is making sure that the caseload ratio is low. It was mentioned that the ICMS, I believe, was a 15 or 20 to 1 caseload ratio, and that the ACT model is a 10 to 1. We always strive, regardless of where we end up within the model, that it needs to land somewhere between 10 to 15 to 1, because that allows for us to be responsive. If your caseload ratio goes beyond that, it really impacts the ability for us to be responsive as providers, which then kind of goes back to the misperception that Housing First doesn't work because the caseload ratio is 30 or 40 to 1. That doesn't really allow for us to provide that person-centered support. We provide mediation with property management. So we work, with both property management at a permanent supportive housing site. We're working with property management in the community, that we're working to remedy and mediate situations that might occur to make sure that we can preserve that relationship and partnership, and ultimately retain their home. We provide support in the community. I mentioned that a lot, that we go to different, locations of supporting them, whether it's with physical health, mental health, income, et cetera. And then, making sure that home visits are reoccurring. So I emphasize this because, sometimes it's very difficult to know how a person is doing in their home if you're not able to see it. And we oftentimes see this sometimes with individuals that might have challenges with keeping their space organized, or might be struggling with hoarding. Being able to kind of see the person in their environment and assessing that and figuring out how you can engage and support them from that perspective. And that concludes my portion.
Okay, thanks so much, Jonathan. Now we're gonna move over to Jolene and and Amiyoko. I'll let you guys take it away.
Good afternoon, everyone. I am Jelaine Gilliam. I'm a licensed clinical social worker. I am currently the Associate Director at CSH in our LA office, but I come with you today as expertise as I previously worked at Pathways to Housing DC, where I oversaw Housing First programs and assertive community treatment teams that you heard about today. You can move on to the next slide. Today, I'm here to discuss the difference between the Housing First approach and the Housing First fidelity model. The approach you see here on the left-hand side is access to low-barrier housing. It relies on the 5 key principles of Housing First, and it seeks to meet someone's needs first and then provide wraparound services. The evidence-based fidelity model requires that a program follows 38 distinct fidelity measures. These measures are delivered by, as we learned today, an assertive community treatment team or an individual case management team. This fidelity model was created in 1992 by Sam Sabera, which was originally delivered to individuals in the scattered site. However, over time, programs have learned how to adjust to operate within the housing market they are living in, as we've heard about project-based housing today. We can move on to the next slide. This slide is the 5 key principles of Housing First. We've heard about them today, so I won't repeat them to be redundant, but if your housing does not provide these 5 key principles, then it's not Housing First. We can move on to the next slide. What I really want to focus on today is the high fidelity Housing First actually requires you to follow 38 individual criteria measures, and they fall within 5 categories. These 5 categories are housing choice and structure, separation of housing and services, service philosophy, service array, and program structure. Funding just the approach and just the philosophy and not the actual Housing First fidelity model will leave the housing system, providers, and participants very disappointed. We can move on to the next slide. In the chat, can you share with me if you've ever seen this scale before? This scale is actually the Pathways to Housing First fidelity scale. This one is from 2010 and is focused on individual case management programs, but there's also a fidelity scale from 2012 that focuses on delivering this from an assertive community treatment lens. So here's a screenshot of the fidelity scale. If you see the category at the top left corner is titled Housing Choice and Structure. So this is one of those categories I was describing. You can also see the scale of scoring from 1 to 4, right? The goal is to reach a 4. As you see, a program can score a 4 if participants have choice in location of their home, decorating, furniture, and other features. Try to really think of this as when you got your own first apartment or home. You had the dignity and the choice to choose how you decorate and select your home. We can move on to slide 5. So category 1, housing choice and structure. When you view that fidelity model, it will describe these 6 criteria and identify what it takes to score 1 to 4. Think of the housing choice and structure category as how it offers participants the dignity of choice in an affordable home. A person housing has no time limit other than what is defined in a lease, and a person should not be sharing living space such as a bathroom, kitchen, or dining room. If so, that's not Housing First to fidelity. The benefit of actually seeing the fidelity scale is that a program can design their program to meet a score of 4. Also, there's a benefit that you can measure your progress often to ensure that you are following Housing First to the fidelity model. We can move on to the next slide. The second category is separation of housing and services. When you view the fidelity scale, it will go into detail and describe criteria 7 through 12 that you see here on the screen. It would also identify what it takes to score a 1 to 4. Think of this category as a right to a home with legal rights as any other renter, despite a participant needing clinical or support services. There is also a commitment in the Housing First Fidelity model that requires you rehouse a person if they lose their housing and that services don't end. The fidelity measure requires also services to be off-site, as my colleague just shared above me. It's important that we go into people's homes, we support them in the community. The reality is people recover in community. Services should be provided where the person is. A library, a park, a grocery store, going to a physical health appointment. These are just some short examples. And we can move on to the next slide. So again, service philosophy is category 3. When you view the fidelity model, it will go into detail and describe criteria 13 through 22 and tell you how you can score a 1 to 4 on the scale. So this category is the skill and heart of delivering life-saving services. It's the ability of a service provider to assess a person's stage of change and match a level of intervention accordingly. Oftentimes we hear that Housing First is not working. This right here, the ability to actually follow the service philosophy, is how you'll see change happen. It's that service provider believing that the person has ability to make choice and learn and grow from their decisions. It's a service provider's ability to walk alongside a person and build understanding, trust, and the accountability needed to recover. It's assertive engagement. A no today is not a no tomorrow. I like to teach service provider staff to understand that if a participant is declining your service, then you aren't providing the right service. The service philosophy teaches you to keep going back, trying again and again, and changing the intervention as needed to help a person recover. We can move on to the next slide. So when you view the fidelity scale, it will also describe criteria 23 through 31, as I've shared, and program has the ability to design their program to score between 1 and 4 with the goal of hitting 4. Think of this category as a catalog book of all the services offered to a participant. As you see them listed here, oftentimes there's myths that it's just housing and services get grouped. But if you look here, there's an opportunity for psychiatric service, integrated stage-wide substance use service, supportive employment service, nursing service, social integration service, 24-hour care, involvement in a person's inpatient treatment. And what's really important for individual case management programs is professional networking. That professional networking is important because individual case management model has to successfully make community referrals for it to be key performance and outcomes. We can move to the next slide. So here is the fidelity measures for a program to deliver Housing First under the ICM model. My colleagues have shared this information today, which is important, the low participant to staff ratio. What I'll pick out, which is really important here, is to have a peer specialist on staff. What I'll also say here, which is also important, is that participants are represented in the program. Participants have voice, their voice matters. They should be aware of and informing policies and programs. Also, what you see there, which is really important, is weekly meetings. This work requires great supervision and support by a leader. You need to be talking out what's going well and what's not going well, and adjusting our services to meet the needs of the community. So the next slide is about program structure for an assertive community treatment team. This category is the backbone of service delivery. This is what holds everything together. The backbone requires, as we see, 1 person to every 10 participants. We've already heard that it's a multidisciplinary team. One thing that I will pick out, something about an ACT team, is to meet the delivery, to provide services to individuals who aren't able to engage in traditional based services. So this is a team of 10 individuals that can meet you in the community and deliver everything you need. And they can see you more than once a week. They can see you twice a day. They can see you daily. And the requirement is that you've seen 4 times a month. Also, something to highlight here is that they're daily meetings. The entire team of 10 staff meet every morning or afternoon to talk about every participant, what's going well, what's not going well, and they create a schedule, a person-centered schedule that a participant has agreed upon to help them move towards recovery. In order to deliver this, we have to fund the fidelity model. In closure, it is important to understand that there is a Pathways to Housing First manual. It's important to read it. There's a fidelity scale that is designed to measure a program's performance. The model can be delivered by an ICM team or an ACT team. The difference is that the ICM programs meet the needs of individuals who can successfully follow through on referrals. And the ACT program meets the needs of individuals who succeed in non-traditional based case management services, where all their needs are provided by one team. There's one door to walk in. So funding the approach and not the fidelity model will leave the housing system, providers, and participants very disappointed. If we want to see success in our Housing First programs here in California, we must fund them to the Housing First fidelity model. Currently in California, services are underfunded, and communities who can benefit from the services that's been outlined throughout this presentation today are left disappointed. When programs aren't funded to Housing First fidelity, some individuals don't get all their needs met, which then impacts that person, their family, their neighbors, and the community. The myths start, and we spend more time debating why Housing First is the solution and less time investigating what policies and funding changes are needed to ensure California delivers Housing First to the actual evidence-based fidelity model. Funding will save lives. Pass it on to Amioko.
Thank you. Shalom, everyone. My name is Amioko Shabazz, and I am a housing justice advocate, and I'm also a tenant justice advocate. And I am here today to talk about the myths. A couple of myths. Myth number 1 would be Housing First let people use drugs, and they offer kind of covered, y'all. I'm sorry about this. And they offer no treatment and services. So according to, we need to know if this is true or not. As Jaylene just said, we focusing too much on the myth. So let's find out if the myth is true or not. So according to the Housing First fidelity model, category 4, the criteria number 23, services are actually built in here into the model. It says housing support. It extends to which program offers services and help participants maintain housing, such as offering assistance with neighborhood orientation, landlord relations, budgeting, and shopping. And so if a person is able to reach the category 4 on the fidelity scale, we can clearly see that the program offers ongoing housing support services, including assistance with neighborhood orientation, landlord relations, budgeting, shopping, property management service, assistance with rent payment, co-signing of the lease. So it's already built into the fidelity model, right? Category 4. So I come to bring some reality to this. So in my expertise, what I come to see is that the services that are focused on, we do get housed. The clients, they do get housed. Barriers are knocked out of the way so that they can get their housing, get their key, and have their living quarters. But the services that I don't see in being offered on here are services like assistance with neighborhood orientation. When you move clients into a new neighborhood and you don't give them assistance with neighborhood orientation, they will tear up not only their apartment, the building, but the neighborhood also will suffer because there's no value or respect for the neighborhood. So I can see how important it is to have neighborhood orientations. And I can tell you about 85 to 90% of the people that I know that are housed in supportive housing and different kind of housings that's under this Housing First model, they're not receiving these services. And so the next one would be shopping. So participants are being put in housing, but are they being introduced to their neighborhood? No, they're not being introduced to the neighborhood. So no one's saying, hey, this is where the local post office is. This is where the local grocery store is. This is where the local beauty supply is. This is where the local drugstore is, so that unfamiliar territory can start to feel familiar and the person can know where to go. Where these are fundamental services that are in here in category 4, but the participants are not receiving this kind of service. The next one would be property management assistance with rent payment and co-leasing. That's working. That one is working about 98%. It's working. People are getting housed. They're not having the barriers to get housed, but then they're abandoned. They're abandoned without the services. And this particular abandonment that happens, it leaves people in a more traumatized state of mind. And everything around them starts to deteriorate. I've seen it with my eyes. And so in that myth number, what is that? Myth number 23. Housing First moves people into housing and offer no support. Well, according to the Fidelity scale, the service array, it's in there. It's built in there. So I believe that no one should have to go without these services, because these fundamental services are the services that starts to build a person that's coming all the way from the ground, and then they got to work themselves up to be a thriving survivor. Because after being homeless, you got to recover from being homeless. So when I see these services, I look at these services as services to help you recover from homeless and get back and find yourself. So the next myth, our next myth would be Housing First leaves people abandoned with no community integration. Now, according to criteria number 28, it says the extent to which services supporting social integration are provided directly by the program. 1, facilitate access and helping participants to develop value social roles and networks within the outside of the program. 2, helping participants develop social competencies to successfully negotiate social relationships. And number 3, enhancing citizenship and participation in social and political venues. So the reality of this is these services are not happening. Along with service array number 23, and then you connect service array number 28, they kind of go hand in hand together. If people are not learning how to come into a community and to respect and value a community, as well as respect and value themselves and their homes, they definitely are not getting the social integration. So therefore, they don't even know how to communicate with neighbors, with staff, with maybe local venues that's in the community. It's not happening. This is the reality. It's not happening. And because it's not happening, there is a large amount of people that are falling through the loop, and they are suffering in Los Angeles. And so I do believe that we should fund the California Fidelity model because it's already built in here. And these services are perfect services that can transform a person's life. And I yield.
Thank you so much, Amiyoko, Angeline. That was really helpful. And I think because we're wanting to get to a longer Q&A section, we're going to skip the Q&A for this specific panel, and we'll put the questions to the whole panel after our last panel presentation. So we're going to move on to the third panel. I'm going to hand it back over to Chris.
Thanks, Sharon. And for this next panel, we're going to talk about efforts to either change or advance and further advance the Housing First model within the state of California. And we have two panelists, my colleague Divya Shiv from Housing California, our senior policy advocate on homelessness, will kick us off. And then I believe Sharon will go through a few slides as well. So over to you, Divya.
Great. Hi, everyone. So today I'm going to talk about some recent challenges to Housing First that we've seen, specifically focusing on bills in the past few years. So since California instituted Housing First in 2016, we've seen challenges that typically fall into two camps. There's the first camp, one camp that seeks to amend and potentially water down Housing First to allow for abstinence-only housing. And, you know, as you've heard from previous panelists, Housing First really champions a harm reduction model that could be at odds with recovery housing. And I'll get more into those bills later on in my presentation. But the second camp of challenges to Housing First really just want to repeal Housing First entirely. So for example, Senate Bill 1284, authored by Bates in 2022, would have eliminated the requirement that state-funded housing programs comply with Housing First. So in effect, getting rid of Housing First. And this bill died in the first committee, but this session we've seen AB 2417, authored by Hoover, which wanted to strike Housing First from California statutes. And while that bill also died in its first committee, the fact that we've seen these bills being introduced to, you know, remove Housing First, I think really point to the precarity of Housing First. And these bills, you know, I think the rationale for these bills is that they have this misperception that Housing First doesn't work because it hasn't solved homelessness in California. However, as previous panelists have talked about, Housing First is a model, it's a practice. It is not the investment needed to, you know, successfully solve homelessness. And it cannot successfully solve homelessness alone without significant investment. So that's the first camp. The second camp is around abstinence-only housing. And, you know, a few of you have alluded to this in the Q&A section, but, you know, since the passage of Senate Bill 1380, we've seen tensions around Housing First and funding recovery housing. And this tension, it really comes down to choice. So if the state were to fund recovery housing, would people truly have a choice between a harm reduction model of Housing First and recovery housing, you know, if the only housing that's being funded in their locality is recovery housing? And some of these bills actually have the potential to water down and even challenge Housing First. So for example, Senate Bill 1438, which was authored by Nielo and has died, it would have authorized the state to fund recovery housing. And it said that tenants would get evicted if they used drugs or alcohol in the same location and the same building where children live. So that is, from what you've heard, it is directly opposed to Housing First. And it's an example of how a bill that's trying to get abstinence only housing could actually directly oppose Housing First principles and challenge Housing First. We also have another bill this session, AB 2893, authored by Ward at Senate Appropriations, that's currently in Senate Appropriations, that the intent of the bill is actually to allow for recovery housing within a Housing First framework. And this is theoretically possible. But again, it all comes down to choice, as you've heard from other panelists. And within this bill, the state could fund recovery housing if it meets certain conditions, like the tenant gets choice between harm reduction housing and abstinence only housing. However, it's important to point out, would this be a true choice? In the bill language, there's a choice, but practically speaking, given the lack of housing and a scarcity of housing, would people truly get that choice between a harm reduction housing and abstinence only housing? Other conditions in the bill language is that the participation in abstinence-only housing should be self-initiated, and tenants should be able to leave whenever they want and get assistance to find other housing that better suits their needs, and that relapse is not a cause for eviction. So again, really just emphasizing what previous panelists have said within the context of amending Housing First to allow for abstinence-only housing and recovery housing. It really just comes down to choice and making sure that we're not watering down and challenging Housing First within that effort. Unfortunately, it's likely that we'll continue to see challenges to Housing First in the years ahead, particularly seeing bills that would seek to repeal Housing First. But it is very encouraging to see you all on this call who are interested in learning about Housing First. And with that, I'll thank you so much for your time, and I'll pass it over to Chris.
Thanks so much, Divya. Alrighty, I think I will turn it over to Sharon, who is pinch hitting for our colleague Mari, who's on the mend today.
Thanks, Chris, and thank you, everybody. And please bear with me since I can't adequately replace Mari. But I'm going to talk a little bit about rental assistance as a resource to advance Housing First. So I think, as several people have mentioned already, unaffordability of housing is the primary driver of homelessness. We see increases in homelessness tied to people having severe housing cost burden, which basically means paying more than half of their incomes on rent. So you see from this slide, over the last 20 years, rent prices in California have dramatically outpaced increases in incomes over the last 20 years. At the same time, federal rental assistance like housing choice vouchers, or people referred to often as Section 8, has failed to keep pace with the increasing number of households with severe housing cost burdens. While the number of federal housing choice vouchers has remained steady, the number of households with the worst case housing needs or severe housing cost burdens has increased significantly. And we're seeing a record number of people in California becoming homeless for the first time, especially since the pandemic relief has started to dry up and eviction protections have ended. So we do see the significant number of people experiencing sheltered and unsheltered homelessness in California, basically after those pandemic relief measures ended. But you could see from this graph that it already was going up in terms of the number of people experiencing homelessness altogether. And again, record numbers of people falling into homelessness for the first time. For this reason, a growing number of Housing First advocates have been calling for ongoing state funding to pay for housing subsidies tied to services funding. Ongoing federal funding for housing and services for veterans experiencing homelessness, and Margot mentioned this at the beginning of the webinar, has resulted in a 55% decline in the number of veterans experiencing homelessness over the last 12 years. So Margot talked about 50%, and then we had like actual bump in how many more veterans were able to exit homelessness for good. And so we do see the more funding for rental assistance or vouchers paired with services offered by the Veterans Administration or the Department of Veterans Affairs has resulted in consistent decreases in homelessness among veterans. Finally, the federal government and the state now allow for some Medicaid resources to be used for services in housing. So services to help people get connected to housing and what is called tenancy sustaining supports in the Medicaid world, which is really services in housing to help people remain stably housed. However, these services are in no way meeting the level of fidelity that Jolene and Amiyoko talked about, or the ACT or intensive case management services that Margot and others have talked about on this webinar. So I'm going to stop there, and we're going to have another Q&A session, and I'll stop sharing my screen so we could ask those questions. And Chris, do you want to start with the first question, and then I will ask a question if we run out. I'll ask one of our questions that we had for the panelists.
Sure. I was just peeling through the Q&A to see what we've got. Oh, that's a good one. There's a question about how Housing First could how to implement Housing First in more rural, lower capacity areas, and how you can staffing challenges, resource challenges, what have you, in those areas, and just kind of how folks have taken steps to overcome those and implement Housing First. So anyone want to take that?
I'll chime in. I mean, I think the question is around, I mean, this might be treading into the distinction that Jaylene and Amiyoko were talking about around the sort of Housing First as a model or an intervention, and I'll call it the more rigorous capital HF model, or the approach, the lowercase as they had it described. I mean, I think the principle is giving access to housing that people would choose, right? And that's dignified and meets their needs. So I've certainly practiced it in contexts and worked in communities where there is not a plethora of 1-bedroom or studio apartments, right? Or not a lot of project-based housing. So I certainly think there's at least a near fidelitous way to practice it in lots of different kinds of housing types, including co-living environments, if the choice, right, is being respected and the dignified and this, like the housing is dignified in that way, right? And it is an environment that meets folks' needs. And that there is not sort of like the traditional kind of house rules model of group homes and stuff, I think is often what is in view here that really works against people being to self-elect. But I personally think that it can be used in much more flexible living environments based on the housing stock available in a given community.
I think I would also add to that, and I think there's kind of a pressure that I think communities sometimes feel that have less resources to try to do more with less. And I would encourage for communities who don't maybe have as many resources to kind of build out the Housing First model to scale out in the way that the community needs, is to still focus on the quality of services, because we've seen oftentimes in certain communities where the funding isn't adequate to even be close to the fidelity of the model, that we've seen that housing retention significantly declines. And the risk that you pose there in the long term is significant doubt in the Housing First model, and it becomes more visible. And you're also losing partnerships with private market rate landlords at the same time. So if I would encourage communities to really kind of focus on quality and not kind of fall into that pressure of doing more with less.
Chris, if I could also add, take a stab to add to what Jonathan said. I do think that there are communities where the local government is working with the housing authority to prioritize turnover of housing choice vouchers to people experiencing homelessness and connecting those vouchers or whatever resources exist in that community for rental assistance that is with private market landlords, that they're pairing that with the services that they have available under their existing programs, including, behavioral health services funding for those with behavioral health conditions. So I have seen that work actually pretty well in a number of jurisdictions that are smaller.
Do you want to take the next one, Sharon?
Yes, why don't you go ahead and do another one, and then I'll ask one of our questions too. That comes up a lot.
I'm wondering if maybe Dakshika or others want to take the Proposition 1 question about Housing First through Prop 1, and whether housing funded under Prop 1 would be required to be Housing First.
The guidelines around the reform piece of BHSA, I think the Department of Healthcare Services will be putting out. And remember, there's a clinical piece and there's a housing piece. On the bond piece, and I think most people know later this year or early next year, just like Home Key, but with a requirement to really provide housing to people who are veterans or others who are at risk or experiencing mental health issues or behavioral health issues and are experiencing homelessness. That will be the target population. So that bond is around building the housing or creating the housing. And this is where the coordinated entry systems and kind of the networks that all of you are involved with the counties and the cities and the service providers, it'll be important to make sure that housing first approaches, housing first models are being used to kind of triage and make sure people are being screened in and not screened out to these housing opportunities when they are created.
Thanks. Over to you, Sharon.
Okay, thanks, Chris. I wanted to ask the panel about a comment that I hear a lot, which is that ever since the Housing First laws were passed in California, homelessness has actually increased. So can a couple of you talk a little bit about why we're seeing increases in homelessness, and are those tied to whether communities are actually advancing housing first? And I think Dakshika and Margot, we're gonna handle this question.
I mean, I think the first thing is sort of going back to your initial statistics class, if you've ever taken, is that correlation isn't causality. Two things happened at once. We know really clearly from tons and tons of evidence that the amount of homelessness in a community is really the only thing it is linearly related to is the availability of housing for the lowest income households. We know when rental prices go up, the amount of homelessness in a community goes up. We have seen in the same time period that that California instituted Housing First. And by the way, the federal government funds are all, homelessness funds are all on a Housing First basis, right? That's like, it isn't that California is an outlier here. It's just that most states don't have a lot of state funding for homelessness. We are totally in line with the federal government, which has said this for a really long time, that if we're going to use federal funds for homelessness, you use it on a Housing First basis. Why did George Bush and then Barack Obama want that to be? Because that's what works better. And that's the most effective way to use a housing. So the reason that homelessness has increased is because our housing crisis has worsened. The disconnect between lowest income households' ability to afford rent and housing costs have gone up. Housing First, it has been sort of the law of the land federally for a much longer period of time. It is the most efficient way to use the housing that we have. So that connection is in people's minds because those things happen at the same time, but it's not caused by this. And frankly, had we not enacted Housing First and insisted on treatment first, we would probably be in a much worse shape than we're in now.
And I'll just add to that because in the slides that Sharon shared that Mari was originally going to share, you can see the escalating cost of rent because fundamentally people become homeless because they can't afford a place to live and they don't make an income that allows them enough income to pay for the rental costs or whatever it is to live in someplace stable. So those kind of structural things are not caused by a housing first approach, just as if you drive a car and you have a seatbelt on, which is a harm reduction model, you are not getting into an accident because of the seatbelt you wore, but the seatbelt hopefully prevents you from dying or having serious injuries. So again, housing first is a harm reduction model, and that is separate and apart from kind of how much housing you need to house somebody or what other kinds of interventions you need to make sure people have enough income and are employed and there's enough housing that's affordable to them. But I will also add here that if you look at the HMIS data that's collected from the 44 continuum of care entities across the state, so Margot mentioned HUD, there are entities called continuum of care entities that receive federal funds and help coordinate services in different regions of the California. There are 44 of these. They collect data through a system called the Homeless Management Information System. And since 2021, the state has been collecting now this information to see the state level information. And what I can share is if Housing First, as you heard, was adopted by the state in 2016, there have been more and more people placed in housing since the adoption of Housing First. So last fiscal year, 72,298 people, so over 72,000 people were placed in permanent housing that was affordable last fiscal year. And that was an increase over the prior fiscal year where 63,000 people were housed in permanent housing. So you can see there's been growth and movement and increase in the number of people being placed in housing, in spite of a housing first approach, if people think that that's preventing people from being housed. So that's one data point, hopefully, that you guys can use, that there are more people being housed every year. And the other data point is, so once people are placed in permanent housing, what the COCs also track is how many people return to homelessness after being placed in permanent housing. And the good news is that 91% of people in California who are placed in permanent housing and are being tracked by the COCs, 91% are staying housed after they're being placed in permanent housing. So you can see that housing really is medicine, a remedy against ongoing homelessness. So now it is true 9% are returning, and I think this is where, as Amiyoko and Jolene mentioned, more fidelity to the model could potentially decrease even further, and we would have 95% staying housed. But I will tell you, 91% is pretty good, and we can only improve on that as we approach this from a housing first kind of intervention.
Sharon, if I could make
yeah.
one more point, I think that helps get at a bit of kind of the category mistake in some ways that that Margot is getting at. I think often when I get asked this question, well, how? I mean, if it's the federal policy and homelessness increase, how is it not a factor, right? Well, I often think it's as if we're saying, to say that, how can Housing First not be part of the problem if homelessness is increased is kind of like saying renewable energies must not work because they haven't mitigated the climate crisis, right? Like, it's really a question of scale. The interventions work just fine, but because they haven't been brought to scale, and there are these other large environmental factors, of course, the larger scale, environment isn't be solved. So it's really a question of the level of implementation. The model is extremely effective.
Thank you, Jonathan. Tim, did you have anything to add?
Yeah, I mean, I think a big part of the issue, I think, is a lot of people don't realize is that during COVID in California, we kind of got together, everyone got together, and we were housing people. We were housing people anywhere and everywhere we could, in hotels, wherever we could. But then that ended, and so we're kind of facing also at the same time we're facing with that backlash of the the COVID pandemic.
Yeah, thanks, Tim. I'll turn it back to you, Chris, to see if there are any other questions that haven't been answered in the Q&A.
Looks like we've gotten to everything. The remaining question is being answered as we speak.
Okay, great. So I did want to just end with the last question I have for all of you, which is where you see potentially opportunities to fund things like assertive community treatment or intensive case management, either through Proposition 1, Behavioral Health Connect, or other kind of initiatives that are out there. We've seen the state come out with a lot of different proposals. So just wanted to throw it out to all of the panelists to see if you have thoughts about that question.
I can start off. I have a couple ideas that have come to mind. Just with the Cal-AIM expansion, they're really expanding the community health worker workforce right now. So I think we need to leverage that and be able to, as this workforce expands, we need to be able to link people that are unhoused. Maybe as they do a housing application, link them up with a community health worker. That to be able to work as like kind of a peer support. Also, peer supports in general. If we could create a more robust program of peer supports and start training people that are housed successfully to become peer support for those that are unhoused, and they could actually act as a bridge between them and the landlords as well. It'll be very beneficial to have some funding for that.
Thank you, Tim. And I think somebody did mention that in one of the Q&A or chat responses as well. So that's really helpful.
I just wanted to second what Tim was saying, because I think Cal-AIM is a resource and opportunity that we haven't fully figured out how to tap into across communities, but has a real advantage where we could create something similar to like an ICM model where you could leverage ECM, which I always forget, it's like enhanced care management, I believe.
Yeah.
With the community supports, housing navigation, housing deposits, along with a day hab is what they call it, where you can pair all of those services together and create something similar to an ICM model. And I think I'm also hearing some communities looking at what can they use Cal-AIM for to help sort of braid and enhance programming before deciding when new funding is coming in to use that to sort of fill the gaps. And so I think Cal-AIM is definitely a real opportunity that we have. And we need to use it quick to prove that it's effective too, right? So it can stay.
Right. And I just said quickly, Sharon, I mean, I think the BHSA side of Prop 1 has a lot of potential just in the sort of reshuffling of the buckets, as it were. That's notwithstanding the fact that where money is being shifted from, things like prevention or otherwise, but the expansion of the requirement for spending on housing, right, interventions and full service partnerships, I think provides a great opportunity to expand truly housing first Fidelity models to say using the housing for permanent housing subsidies, those full service partnerships that most communities, at least in ours, do follow the ACT Fidelity model. That is an opportunity for many communities to scale those community-based support programs, spend more on subsidies and more on those full service partnerships to really provide that high level of service. So that is a byproduct of those changes, I think, that I'm certainly trying to make sure, like, of the decisions we make, let's do more of those programs because we know they work.
Thanks, Jonathan. Okay, I think that's all we have time for today. I do have a few last things to share with everybody about Housing First and homelessness. So if people are interested, I will be sending out the slides and the recording to all those who registered. And several of these materials that I have on the screen right now were mentioned during the session. So this is on the slides. And so if you're interested in exploring further, please feel free to link to any of these studies or the fidelity scales or list of studies that exist, as well as the homeless data integration system, which Dakshika had mentioned. Also wanted to share with you upcoming educational events that either CSH or our partners are providing in the next few months. We know that there's going to be a legislative briefing on the Grants Pass versus Johnson Supreme Court decision and its impact on California's communities on October 22nd in Sacramento in person. That will be at 10 a.m. on that day. We're also going to be doing a film screening with a reception and panel discussion on the documentary Beyond the Bridge, A Solution to Homelessness. Housing First is mentioned in that, but it's not just about Housing First. That will be sometime in the fall, probably October, and it'll be in the early evening in Sacramento. There'll also be a legislative briefing on the level of funding that the state has invested recently and why homelessness still increases. And that will be sometime toward the end of the year or the beginning of next year. And then finally, a coalition is putting together a legislative briefing around homelessness among older adults and people with disabilities. And again, that will be sometime in December or January. So just wanted to thank all of the panelists so much for spending 2 hours plus their time preparing for this webinar, as well as all of the attendees for sticking in with us over this webinar and really being receptive to hearing a lot of information and data. And so appreciate your interest in this topic and wanting to be educated, as well as the panelists. If you have any questions that didn't get answered or need further information, please feel free to reach out to me or to Chris. And I hope everybody has a wonderful evening. Thank you all very much.
Bye, Sharon. Thank you. I was looking
Oh,
at